Good afternoon, everyone. Welcome to the festive edition of the Centre for Care and Circle seminar series. Thanks for making the time in amongst Christmas deadlines, nativity plays, whatever it is that is taking up your time at the moment. For those who don't know, I'm Nathan Hughes. I'm co-director of Circle and deputy director of the Centre for Care, and I'm going to act as chair today. And we're delighted to have two members of the Centre for Care with us presenting today, both based at the Health Services Management Centre at the University of Birmingham. I'm sure they need no introduction to you all, but it's Catherine Needham, Professor of Public Policy and Public Management, and Emily Byrne, who's Centre for Care Research Associate. For those that don't know about Catherine and Emily's work, they lead the centre's theme of work here on care as a complex adaptive ecosystem. So it takes a complex systems approach to understand how interacting parts, so services, markets, families, communities continually kind of shape and reshape how social care is organised and experienced, and really helps us to focus both on the very visible parts of social care, the kind of statutory systems, but also the less visible community supports, and to think about how these come together to help care ecosystems flourish. If you haven't seen their now famous care ecosystem illustration that captures this, you may see it shortly, and if not, head to our website to have a look at it. So today's presentation is going to draw on this work. So they're going to share some early findings about their study of the potential of patch-based commissioning to improve outcomes in home care and the kind of the factors that enable and hinder this. So they're going to talk for about 30 minutes, we think, and this is going to give us plenty of time at the end for your questions, comments, reflections. I don't know, Catherine and Emily, be particularly keen to hear your feedback on their kind of emerging thinking here. If you prefer not to speak, you can obviously add questions and comments to the chat, and I'll happily read them out for you. Hand over to Catherine, and I think firstly to Emily.
Yep, that's great. Thank you very much, Nathan. So as Nathan said, we'll be reflecting today on some work we are doing to explore the use of patch-based commissioning. So a particular way of commissioning home care services and exploring whether this approach has the potential to improve outcomes in home care. So, as usual, here's the funding disclaimer. The views we present are our own rather than that of our funders. So just to give an introduction about patch-based commissioning and just what it is that we mean when we're talking about patch-based commissioning. So I'm sure everyone here on the call is aware of the concerns around the sustainability and the quality of home care services. And it's recognised that providers are operating within sort of very difficult market conditions, sort of great concerns around the recruitment and retention of the workforce, and also people's experiences of drawing on home care services and the quality of services that's received. So it's often the case that home care services are commissioned via framework contracts. So there'll be a list of providers that operate across the whole of the local authority geography. However, as we can see in the diagram here, patch-based commissioning, which is also known as neighbourhood-based commissioning, is this idea that you take the geography of the local authority and split it into different areas or zones, and then within each area or zone, a provider delivers care within that area. And we're seeing that it's becoming sort of an increasingly popular model within local authorities, and it's seen as being, a potential route through some of the challenges and the difficulties around the sort of design and delivery of home care. So this idea of patch-based working, we can see that it aligns with the neighbourhood approach of integrated care systems, as well as that within the NHS and the focus on localities. So here we're reporting on initial findings of an ongoing project exploring patch-based commissioning within a local authority. And so we initially started working in a local authority to try and explore and understand sort of change processes within adult social care. And then it became quickly apparent that home care provision was being recommissioned, and sort of this patch-based model was being used. And so that's what we decided to focus in, home in on. And as a result, we developed the following research questions that we'll really use today to structure our presentation. And those questions are: to what extent does patch-based commissioning strengthen the sustainability of the home care market? And also, what factors support or inhibit the introduction of patch-based approaches to commissioning? So just to give an oversight or an overview of our methods. So we are working in one case site, which we've decided to refer to as Urbanry. We're calling on 30 interviews here, semi-structured interviews. So we spoke to local authority staff, providers of home care, as well as local stakeholders within the area as well. We also undertook some meeting observations. So those meetings that were available online, there's some archived meetings as well, where adult social care was discussed, particularly around home care and the recommissioning of home care. And we also explored policy documents, so documents that are publicly available online, again, sort of referring to sort of what's going on within the adult social care system, along with the design and delivery of home care, with a particular focus on the recommissioning of those services. So just to give a bit of an sort of overview of the home care model and sort of the changes that were sort of being made within the new approach to commissioning home care. So previously, within the local authority area, there was a high number of providers that could potentially operate within the local area on that framework, on the home care framework. But actually, a decision was made to reduce the number of providers that are commissioned. So again, taking the local authority area, splitting it up into different zones. And then each provider has a geographical patch that they will deliver services in for several years. And those providers were selected based on kind of a Goldilocks principle. So they're either not too big and not too small, with each provider expected to deliver between 1.5 and 2.5 thousand hours of care per week. And so really this idea is that if a provider was too small, they might fall victim to, for example, sort of staff being ill, and that might create difficulties around the sort of sustainability of service provision. But again, if a provider's too big, there's a sense that potentially that sort of connection and link to the locality may be lost. So again, sort of focusing on that sort of, as we've referred to, sort of the Goldilocks principle there. And so the idea of patch-based commissioning was that it would reduce travel time. So previously it was the case when the framework contract was in operation, it was found that providers were sort of almost crisscrossing each other across the city, which was sort of seen to be very inefficient, potentially also having an environmental impact, sort of lots of people sort of driving around in their cars to deliver care. And so this idea of working through patches would reduce travel time and also address some of the environmental impacts and concerns. But also working on that local level would help to build collaborative relationships, both between providers. So as each provider has responsibility for delivering care within their patch, it was seen that it would reduce competition between providers and increase collaboration, and also develop better relationships and closer relationships between the local authority and providers as well. And so within sort of the recommissioning of home care, there was an emphasis placed on being focused on outcomes rather than time and task. Although it should be noted that commissioning is based on sort of guaranteed hours, so each provider has that guaranteed sort of number of hours that they are commissioned to deliver. And so it's not the case that the model is built on outcomes-based commissioning. And providers are expected to take an enabling approach. And so that means sort of working with the person who's drawing on care and support to try and understand ways in which they can be supported, and to work with the provider to increase their independence, and potentially sort of help them sort of build up to doing tasks that maybe they weren't doing before. And the idea is, and the assumption is, that this has the potential to reduce the number of hours that individuals will draw on. But there would also be regular reviews, again, to ensure that that level of care was appropriate to people's needs. There was also an expectation that providers would develop connections with the voluntary and community sector within their area. And really that links to that, the enabling approach. So by understanding sort of what's available, community associations and voluntary organisations, there's a sense that those opportunities could be kind of used within the local areas. So if someone's experiencing sort of social isolation, it's the case that the provider would be able to signpost that person to different provisions sort of within the local community. So a further sort of feature of the model is that care recipients can't necessarily choose their provider. So within sort of a geographical patch, there's a provider that delivers the care. Unless it can be demonstrated that the person has needs that can't necessarily be met within the patch, by the provider. So now sort of thinking about some of the reflections from our interviewees and what they sort of made of some of the aims of the model and whether the model was kind of achieving some of those aims. Thinking first about the idea of this focus on outcomes. So providers would work with people during on care to identify the outcomes that matter to them, and also sort of how those hours of care can be used to support the individual to achieve what it is that they want to do. And so, as mentioned before, it's not the case that the model is based on outcomes-based commissioning. But there are sort of the aims and sort of the aspiration to shift from time and task towards outcomes-based commissioning. But it's recognised that, sort of the model it's not quite there yet. But as you can see from the quotations here from providers, there's a sense that this model is doing something different. So from the first quote here, we can see that there's this idea of sort of social work being used to saying, we need to do this for the person drawing care. It's sort of quite a sort of on high kind of declaration, but actually we're progressing to say we're working with the person drawing on care, saying these are the things we want and these are the hours. And again, it's that sort of negotiated process of understanding what it is that people want to achieve. And this was seen as, in the second quote, as an improvement to the way that the home care used to be delivered. So there's a greater sense of flexibility. So it used to be the case that the care workforce were very much constrained to what was in the care plan. But actually now the idea of there being sort of a commissioned set number of hours has increased the potential sort of flexibility within the care and support that's delivered. So there's the potential, so as long as personal care is delivered, we can work with the person drawing on care and support to understand what it is that they want to do that day. So, for example, in the quote here, there's an idea of someone just wanting to go and sit outside on a nice sunny day and sort of enjoy the weather. So again, there's a sense of change and that the model is providing something different. There's also a focus kind of on a new version of choice, kind of a reconceptualized idea of choice. So it's something, a criticism that's been levied towards patch-based commissioning, is this idea that it reduces choice. But actually our interviewees reflected on, maybe what we understand as being choice should be shifted. So as you can see in the quote here, there's a sense of when the framework was in operation, it was a case that a call would be made off the framework, and whichever provider was the fastest to respond, that would be the provider that someone would be given. And so there's the interview here is kind of questioning, like, well, is their choice evident within this arrangement anyway? And actually challenging, did we actually have choice at this point? And I suppose maybe choice is conceptualized within patch-based commissioning as sort of the coming through that relationship that the aim is for the provider to develop with the person drawing on care and support, to work with them to understand what it is that they want to achieve. And so that sort of developing that relationship has the potential to kind of expand the choice of the individual rather than seeing sort of choice as being sort of rooted in which provider delivers your care. There's also a focus on the local that came through. So people did agree sort of this idea was built on the intention to try and sort of address sort of issues around the climate crisis. And so trying to reduce the use of cars and this idea of being more localized. People would be working in their own area. Potentially, it would be less stressful, so people wouldn't be stuck in traffic. Everyone who people need to deliver care up to would be sort of on quite close to one another. So it's just is seen to be a more efficient way of working. And also, people could appreciate sort of this idea of working on a sort of patch-based, locality-based way, and that sort of understanding that care workers would be sort of embedded within the local area more. They'd have sort of a greater knowledge and understanding of the opportunities that are available to them within the patch of those sort of different community associations and voluntary organisations that operate within an area. And that, you can, through that sort of natural kind of understanding that just comes from working within one area, as you can see in the final sentence, that means you have a more sort of cohesive, more knowledgeable workforce that can tap into that localized information as well. And the potential there to sort of take that enabling approach and help to potentially improve outcomes for people drawing on care. So it was recognised that there's a journey, really, Urban Re's on a journey towards being sort of outcomes led. So there's a shift away, sort of again, the intention to shift away from a time and task approach towards outcomes-based commissioning. And really the first aim and the first sort of thing that needs to be done is to sort of achieve a resilient home care provision. So to sort of strengthen the home care market and to ensure that it's sustainable and also affordable. And so flowing from that is the idea that providers are expected, as I said, to take a kind of strength-based enabling approach. And there's an assumption that the number of hours that someone drawing on care would receive potentially could decrease if that was seen to be appropriate, again, with regular reviews. Also, investment in technology-enabled care was also intended to, again, reduce provision, to ensure kind of this idea of care optimization, the opportunity that some calls may potentially be able to move online again, if appropriate. And within the model, there was the intention to introduce trusted reviewers. So providers potentially could work to sort of flex up or down the number of hours someone drawing on care would receive, up to sort of 7 hours per week for 6 weeks. But we did find that there are sort of delays in introducing this role. But providers are also part of multidisciplinary teams within their area, and that's kind of really enabled by working on this patch basis. So relationships between social workers, occupational therapists, district nurses, and also providers is strengthened in order to facilitate holistic support. And patches do map onto primary care networks. But there was a sense from our interviewees that the model wouldn't be able to be fully outcomes-based until workers could be moved onto a shift or salaried basis, as that would maximise the flexibility required to be sort of fully outcomes-based. So there is sort of, again, like the aspiration to do this in future, but it was recognised that the costs of doing this are incredibly high. And so really just thinking about the experience of patch-based commissioning after the first year. So as mentioned, there was a shift and a reduction in the number of providers that had to exit local authority commissioned services. And that transition to some extent was quite painful. As sort of as a shift and a change from people drawing on care to different providers, and some of those sort of the transition from one provider to the other maybe wasn't as smooth as could be. We also found that there were high rates of exceptions and spot purchases from providers outside of the patch. But we did find that there were improvements in hospital discharge processes. And so people within hospitals found it much easier that they sort of knew which provider they had to contact. They sort of developed a relationship with that person. They knew the person by name. And that allowed sort of closer working between providers and also social workers as well. We did find at the moment that there was less emphasis placed on developing links with the voluntary and community sector than expected. So it was the case that providers were reflecting on the fact of we've had to change our approach. We're focused on kind of delivering what we need to do, but this is our aspiration for the future. This is something we'll be looking at to do in future. There are also very high levels of international recruitment, and obviously that reflects sort of some of the dependencies and the links there with the visa system. And so it wasn't necessarily something that the local authority had planned for. But also we found it was too early at this moment to assess whether outcomes have improved. So I'm just going to hand over to Catherine now, who will talk us through some of the preliminary conclusions.
Thanks, Emily. Yeah, hopefully people can hear me. And yeah, so I know you came here because we had outcomes in the title to hear about outcomes. But yeah, as Emily said, it's both too early to know whether they've improved, but also the data is not being collected by providers or the local authority in comparable ways so that we will know whether outcomes have improved. So that's, I think it's, it's partly about saying what we've got here is a sort of immature model that has potential and can capture that, but isn't capturing it at the moment. So, in terms of then thinking about what the conclusions are from this research, so I guess one kind of set of conclusions might be that the sorts of things that we've been seeing and maybe some of the limitations of the model are kind of transitional issues. So we were looking at this as it sort of rolled out in real time and in through year one. Um, so one of the things we're doing is looking at the kind of theory of change, the kind of program theory behind it. And we argued that there is a plausible theory of change here, that some of the assumptions behind this model do seem to be um, in line with what looks like it will be effective commissioning that would make the move towards outcomes longer term. So the idea of kind of collaborating more closely with providers to do long-term commissioning over a kind of 7-year period, that is the basis for potentially a more sustainable local market that doesn't have some of the kind of the risks and volatility that we know lots of social care markets have, and that by building closer relationships, you should reduce things like contract management time and be able to kind of sort of resolve things more quickly. We think the idea of kind of embedding providers in patches is a sensible one, and the idea, certainly in the design of it, if not in the development of it in year one, that you can do that to kind of embed people in that kind of in their broader localities, in the voluntary and community sector, in kind of connecting people up with some of that kind of local community infrastructure. It's a model that looks like it works well for hospital discharge, and it's potentially part of that kind of broader NHS neighbourhood model that's kind of in development, and linking into that with the kind of broader work around prevention because of kind of the idea that if you can kind of embed people better in their local communities, they can draw on things like kind of natural networks and forms of support, which might keep people at a kind of lower level of need in terms of social care and health needs potentially for longer. So we might say that although there are some elements of it that didn't work as planned. The higher level of spot purchasing, for example, that some of that is inevitable when you make a kind of a big change of system. Next slide, please.
Oh, sorry, just trying to shift this. Oh, there we go.
Thank you. But I think we would say that the assumption that there is a kind of steady state that's just around the corner is one of the kind of logical fallacies in social care policy design, because we know that there's so much turbulence and churn, so much of that is out of the control of the local authority, that we would say that social care is always in transition. So, what we saw around the visa changes, bringing in international workers, that was not a feature of the model. As I think someone's put in the chat, that's a feature of, that's been home care in the UK over the last few years. But it does mean that there's potentially, in the site that we're looking at, there was a kind of 50% of the commissioned home care workers were coming in as international workers. And obviously then some of the things you're trying to achieve, like embedding people more in their kind of local neighbourhoods, can be difficult if you've got people who don't themselves have any familiarity with that local neighbourhood. So it's the kind of the sense that you've got, whether it's the international migration context, whether it's things like the national insurance rises, local government reorganisation. There's so many different things going on in the policy space, as well as in the kind of marketplace. So we've spoken to other places that have done patch-based commissioning and said it just didn't work because the providers themselves were constantly taking each other over or withdrawing from the market or doing other things, which meant we didn't have this sort of stable body of providers who would kind of be allocated a patch and sort of stay there. And even in Urbanbury, where they've got this kind of nice, elegant model, we know that that's only kind of, you can kind of look down at the commissioned home care, but that's, you just have to pan out a little bit to see the broader home care ecosystem. I'm not even talking yet about residential care or community care and, or, some of that broader stuff. That there are about 80 home care providers in this setting. So that's already kind of quite a complicated infrastructure of different providers on the scene, potentially as rivals for direct payment purchase, self-funders, etc. So there are some interdependencies there. And so what we would kind of say is that rather than seeing things as a transition issue, it's this sense that kind of we always need to be alert to ways in which new models, for all of their benefits, are going to decay and decline because of the limits in a cash strapped system where, we would say, I'm sure a lot of people on the call would agree, there is not enough money to do this work well and properly. Then we'd see that ultimately you come up against the limits of each model. And Max French and others have argued that that's partly just a feature of complexity, is that because of all the things you cannot control and their interplay and feedback loops, the effectiveness of any kind of intervention decays over time. Next slide, please. So one of the things we might think about was, if we think there's a plausible theory of change here and we like it as a model, are there things that we can put in place to minimize the decay, so to try to kind of stabilize this model for a longer period? So one of the things that Emily and I have been doing is talking to other places, other localities which have tried patch-based commissioning and have moved away from it because in the end they reach that kind of decay point. Supporting Urbanbury to think about what some of the risk factors might be and how they might be anticipated. So one of those was around timing. So some of the areas said that they felt that the Big Bang approach, where you just kind of turn off one contract one day and turn on a new patch-based slim down contract another day, is too risky for them. That really destabilized the model. They proposed a kind of more gradual introduction. Obviously, that's not what we've had in Urbanbury, but for other places thinking about it, it's worth thinking about what the kind of pros and cons are of doing it in one go or doing it gradually. There's issues around the market. So in Urbanbury, they've been able to work with a smaller number of providers and develop quite close relationships. But in other areas, they said providers don't like the patch-based model because the nature of for-profit providers is they want to grow, and it's really no use whatsoever to them to say you cannot grow. You're going to work in this patch. Other patches are other providers, and we're going to kind of hem you in to a certain number of hours. So in some areas, it was the providers who kind of rebelled against the model. So that's another kind of feature that needs to be thought about. Next slide. There are different payment models, as Emily said. In Urbanbury, it's about minimum guaranteed hours for providers, but other places have tried to do it kind of with paying by planned visits, paying by block. There are different kinds of models. Nobody, the places that we've spoken to aren't yet doing it by outcomes, because we know that's really complicated to do and doesn't necessarily give the providers what they need. So there's the kind of different ways to experiment with different payment models, which have pros and cons. And then some sense in some areas that social workers weren't necessarily on board with the patch-based model, partly because it does mean that there is a risk to the kind of choice and control paradigm of kind of people being able to choose providers, get a good fit with their needs and what they want. That potentially that could be limited. But as Emily said, partly that was always a slightly kind of abstract choice because of the problems of the market, that maybe people don't have any less choice now than they had before. Next slide. There's issues about the resilience of the model. So a couple of places where we spoke to, they'd tried it and it had fallen apart during COVID. Obviously, that was a kind of, I don't know if we call it a kind of a unicorn event, a one-off event, but clearly there are reasons why maybe it isn't, and there are other forms of crisis to anticipate. So if you're moving towards this model, you do need to think about its resilience in times of intense strain and pressure. And then there's the issue around kind of whether it's an urban model, the kind of nature of a kind of a neighborhood or a patch, is kind of an urban idea. So we know that places that have tried to do it in rural areas have often had to do something slightly different or have backed away from it more quickly, because you just don't necessarily have the concentration to really make the kind of efficiencies work when people are much more spread out. So certainly in one of the areas we spoke to, they only did patch-based in their kind of urban setting. When it came to rural kind of outposts of the local authority, they just did something different because it wasn't necessarily going to work. So, and just to finish, really, I think we're one of the things that we're really kind of interested in is the kind of the optimistic seizing of a new model, which is what we would see in urban breeds. There's kind of lots of positivity and optimism about the potential of this model to overcome some of the structural and systemic limitations within social care. And we see that optimism from both the local authority and from the providers. And because we all know that there's all sorts of risks and pressures in social care, I mean, the whole kind of visa regime remains very fragile, and there's all sorts of uncertainties about what will happen when people get to the end of their kind of their 5 year period of working, whether that will be a new form of destabilization. So partly, I think what we're sort of picking up on is this notion of what John Boswell calls kind of magical thinking, the kind of ability to think that a new model will be able to come along and solve lots of different problems, and this will be the thing, this will kind of will fix things. Um, and I think what's interesting from John Boswell and that why we kind of like his book is he argues this isn't just that kind of policy actors working in, say, local authorities are kind of naive or just a bit overly simplistic, and then kind of academics come along with their kind of complex models and they really know what's going on. It's about the kind of the way in which all of us have to kind of set aside some of our skepticism in order to kind of make things happen, in order to make change in very difficult circumstances and to make kind of incremental action happen. We have to kind of work in these conditions of radical uncertainty because there is no kind of certainty coming around the corner. Next slide, please. So thinking about that kind of what's going on in this area. So partly this sense of kind of how are people kind of telling us about what's going on? Is this a case of kind of over optimism, or is it a case of kind of pragmatically trying to make change in very difficult circumstances and something that we're really keen to support? Got the sliced bread there in the sense of, for some people, this patch basis is the best thing since sliced bread. This is going to solve all the problems. I think we've identified some of the ways, the risk factors going forward about whether it will start to kind of come up against the same challenges as lots of other social care models around, the fact that there isn't enough staff and those staff aren't paid well, and lots of people's experience of receiving social care is not necessarily what we would want it to be. So for us, we're carrying on working in urban breed to watch it over a kind of longer time period. We're doing some follow-up interviews with providers to see after year one how their experience is is kind of developing, and thinking about kind of what there is to be learned, because we know there are other places that have done the kind of patch-based model about how we might learn from a number of different places to think about how to make this a kind of sustainable intervention within social care, and one which kind of anticipates some of the complexity around the kind of the potential changes to the migrant regime or whatever, rather than kind of having that as a kind of an unpleasant surprise that then has to be kind of managed and threatens the viability of the model itself. And then thinking about this notion of kind of magical thinking as a kind of coping strategy, and learning from kind of how the people who are doing this work on the ground, how they sustain that kind of optimism and incremental change to move forward in social care when we all know the kind of myriad challenges, the lack of kind of clear national steer on how we might move forward so far anyway. That means that there is a lot to be done locally just to keep moving in positive direction, to keep trying new things, to keep experimenting, to keep learning, and we're really kind of keen to get a sense of what are the places that do that well, and what can we learn from them. So I think that's us. Some references there, but happy to move into questions.
Yeah, thank you, Emily and Catherine. Yeah, wonderful stuff. Really interesting work. And